Then we have another speaker, Professor Liao, Wei-Chih Liao from Taiwan University Hospital. Now he is associate professor of Taiwan University, and he will give the same talk about the experience of Eastern country. Professor Liao, please.
Thank you, Mr. Chairman, for the kind introduction. So, ladies and gentlemen, good morning. So, my task is to answer the question about what is the best approach for biopsy and stenting hilar cholangiocarcinoma. I think this is an area with a lot of controversies. And today, what I'm going to do is try to summarize the available evidence to try to better answer this question. I have no conflicts of interest to disclose. So I think the most commonly used methods of tissue sampling is ERCP-based techniques, and many the Professor Lee has just mentioned. The first is brush cytology, and the second is forceps biopsy. And then we have now cholangioscopy-directed biopsy. And we also have the endoscopic ultrasound-guided fine needle aspiration or biopsy for tissue acquisition. And lastly, we can also perform CT or MRI-guided percutaneous biopsy. However, because of the risk of seeding along the needle tract, I think this modality is now rarely used. Okay, so this picture shows how the ERCP-based techniques are performed. The last is a brush cytology. So we pass the brush cytology into the bile duct onto the tumor and then to get some cells for subsequent cytology analysis. And the right is a forceps biopsy. We use a forceps to pass into the bile duct and do tissue sampling. Okay, so this is a meta-analysis of 9 studies that compared brush cytology and forceps biopsy for biliary strictures. And you can see that for brush cytology, the sensitivity ranged from below 20% to 70%. So the pooled sensitivity is 45%. And for intraductal biopsy, the sensitivity is 48%. So these two modalities seem to be comparable in terms of sensitivity. If you combine the two procedures together, then the pooled sensitivity is 59%, seems to be better than either one alone. With respect to specificity, either procedure or both combined has a specificity in excess of 99%. So the bottom line is the two procedures are comparable in terms of sensitivity. However, the sensitivity is only modest, actually it's quite low, and combining the two actually only modestly improved the sensitivity. Therefore, it is not possible to exclude cancer based on a negative cytology or intraductal biopsy. Okay. And now we have the peroral cholangioscopy. With this, we can visualize the lining of the bile duct. If we see dilated or tortuous vessels or nodules or masses, it's highly suggestive of cancer. And also we can, under direct vision, do targeted biopsy on the suspected areas. Okay, so this is a meta-analysis of studies that evaluated cholangioscopy-guided biopsy in cases who have suspected biliary cancer, but with a previous negative or non-diagnostic biopsy or brush cytology. And the pool sensitivity for cholangioscopy-guided biopsy is 66%, and the pool specificity is 97%. So these results suggest that cholangioscopy-guided biopsy is useful for cases with suspected biliary cancer, but a negative or non-diagnostic brush cytology or forceps biopsy. So these are ERCP-based techniques which tackle the lesion from inside the bile duct. Instead, with the EUS, we can tackle the lesion from outside of the bile duct. This shows that the biliary stricture can actually be easily seen under EUS, and then we can perform fine needle aspiration or biopsy for tissue acquisition. And there are 2 studies that specifically looked at Hilar strictures with non-diagnostic or negative brush cytology and or biopsy. And the result shows a sensitivity of 77% and 91% with EUS FNA. However, as Professor Lee just mentioned, because of the risk of tumor seeding along the tract, I think this should only be reserved for patients with unresectable lesions. Okay, so I will move on to drainage. I think that when we consider about drainage, the most important thing is to think whether the tumor is resectable or not. In other words, whether we are going to do a preoperative drainage before surgical resection, or we are contemplating a palliative drainage in patients with unresectable cancer. Oops. Okay. In terms of preoperative drainage, whether to drain or not to drain is a key question. The rationale for preoperative drainage is to drain the liver so that the liver function improves from obstruction and may offer a better post-operative outcome. However, in a meta-analysis of 9 retrospective studies involving about 900 patients, preoperative drainage was associated with a higher post-operative morbidity, with a pooled risk ratio of 1.3. And then most of this was attributed to a higher risk of wound infection after operation. In terms of post-operative mortality, there was no significant difference between patients receiving preoperative drainage and those who did not receive drainage. So the bottom line is preoperative drainage may increase the risk of post-operative morbidity, and it seems not improving the post-operative mortality. Therefore, the guideline of the European Society of Gastrointestinal Endoscopy argues against the routine use of preoperative drainage because it increases post-operative morbidity without improving mortality. However, it cautioned that this statement was a weak statement based on low-quality evidence because you have seen that the previous studies were all retrospective, non-randomized studies. And it also highlighted that in selected cases, preoperative drainage may be indicated. For example, in cases with cholangitis, or in cases with a future liver remnant of 30% or less, because this patient has been shown to have a high risk of liver failure after liver resection. Okay. Also, if we decide to perform preoperative drainage, then which is the better route? Is it percutaneous drainage or ERCP-based endoscopic drainage? So this is a meta-analysis of 4 retrospective studies, and it showed that endoscopic drainage had a higher risk of cholangitis after the procedure, as well as procedure-related morbidity is higher. And the endoscopic drainage also has a higher need for conversion to percutaneous drainage. In terms of post-operative morbidity or mortality, there was no difference between either routes. However, that is the short-term result. How about the long-term result? There was a study that looked at the long-term survival after liver resection, and they found that patients who had preoperative drainage had increased the risk of seeding and reduced post-operative survival compared with patients who did not receive preoperative drainage. However, another study showed there was no difference between patients who received drainage or not received drainage. So I think this is an area of controversy. So we still do not know when or which subset of patients should be preoperative drained, and what is the ideal route? Is it percutaneous drainage or ERCP? And the available literature, I think, are flawed in terms of the study design. Also, there was no stratification by the business type. Okay, then I'll talk about the palliative drainage. I think there are a few key factors that we need to think before attempting to do palliative drainage. Of course, it's the business type, and also the modality that we are going to use, and the stent. Is it cover stent or plastic stent? And the number of stents. Should we drain the right lobe, one lobe, or we drain both lobes? According to the ESG guideline, it suggests for bismuth 1 or 2, ERCP is the preferred route, because for bismuth type 1 or 2, the anatomy is quite similar as distal biliary stricture and can be completely drained with either 1 or 2 stents. However, for bismuth 3 or 4, there is a high chance that endoscopic drainage may not be complete. Therefore, the ESG guidelines suggest PTBD or a combination of PTBD and ERCP in these patients. The reason for placing percutaneous drainage before endoscopic drainage is that in a previous meta-analysis, you can see that in patients with bismuth 3 or 4 lesions, percutaneous drainage was associated with a higher chance of success compared with ERCP. Okay. And the overall adverse events and the 30-day mortality was comparable. However, it should be noted that the success and the complication rate of endoscopic drainage is determined by the local expertise. So the choice between percutaneous drainage and ERCP endoscopic drainage should be considered in a case-by-case scenario. In terms of stent selection, I think now metal stents are the standard of care. In this randomized control trial, metal stents have a longer patency compared with plastic stents, although the patient survival seems to be comparable. And a subsequent meta-analysis confirmed the finding. They found that metal stents are better in terms of 30-day occlusion rate and a lower long-term occlusion rate, and also a higher success of stent insertion compared with plastic stent, and are less likely to need future reintervention. And the risk of post-procedural cholangitis is also lower with metal stent. So for palliative drainage, metal stent is the standard of care. And in terms of the volume of liver to be drained, Professor Liao also mentioned about the importance of draining more than 50% of liver. This is because a previous retrospective comparative study found that patients with drainage of more than 50% of the liver had a longer survival compared with patients who had less than 50% of liver drained. Therefore, now we aim for draining more than 50% of the liver. And to drain 50% or more, usually we need to drain bilaterally instead of putting in only one stent. And this randomized control trial confirmed bilateral stenting improves in stent patency. Although the survival was marginal, did not reach statistical significance. But you can see there seems to be a trend toward longer survival in patients receiving bilateral stenting. Bilateral stenting also has a higher clinical success, and a lower rate of reintervention, longer patency. For bilateral stenting. I think there are now two endoscopic techniques. First is so-called side-by-side stenting. We place two stents side by side, parallel to each other. And the next is stenting stent technique, in which the second stent is placed through the mesh of the first stent. So this technique is mainly more commonly used and advocated in Asia. And this is one of our cases in which we put in two stents side by side. And this is a case with bismuth 3A, and the stent patency was about 11 months. And this is another case with bismuth type 2. And in this case, we used the stent-in-stent technique to put in two stents. And the stent lasted about 15 months. So far, there is no evidence to suggest that which of the technique is better than the other. I think we should more evidence. And also, it depends on the anatomy of the patient and also the endoscopist's preference. So in summary, the first-line method for tissue acquisition is brush cytology and forceps biopsy. And in our center, if this could not reach a definite diagnosis, we move on to cholangioscopy-guided biopsy. And ESFNA can be useful in cases with unresectable cancer and inconclusive or negative results from other examinations. Preoperative drainage may be needed in selected patients. However, we need more research, better quality evidence to clearly define what subset of patients need preoperative drainage. And the route of palliative drainage depends on the anatomy and the local expertise. And very often, multiple approaches, such as a combination of ERCP and PTBD, is needed. And lastly, an emerging technique is US-guided biliary drainage. And this often occurs when patients have multiple ERCP and PTBD, and no longer can be easily salvaged with more ERCP or PTBD. In that case, US biliary drainage is a promising technique to drain the bile duct. So thank you for your attention.